Indeed, right. It's just gone 6 o'clock here on this Wednesday afternoon / evening. And of course, we have interrupted Karim's drive time show because we have got our Brent Health Matters show. This is the panel show that we do at the end of every single month in conjunction with Brent Council, where we talk about issues that are affecting our community that need to be discussed and we need to raise awareness for. I go by the name of Sashel and I'm going to be your host for this evening, and I've got an amazing panel today. Really excited to talk about this one because it's a topic that we have to make sure we raise awareness for. And if you do want to get involved, you already know you can hit us up on the socials at the Beat 1036 FM on Facebook, Instagram and Twitter. Now, it's only right that I introduce our panel, and they are incredible today because they have got such a wealth of experience. I'm going to start with Dr. William Tay. Dr. Tay, how are you? Can you hear me?
Yes, indeed. Good evening.
Good evening. Thank you for joining us today. How are you?
Good. Looking forward to taking part.
Indeed. Right. Now, can you tell us a little bit about what you do? Because you are a consultant radiologist and director of breast screening for the North London Breast Screening Service at the Royal Free Hospital, right?
That's correct.
So for our listeners that don't really know what that means, can you tell us in layman's terms, what is it that you do?
So I'm a specialist consultant who specializes in breast imaging. So I'm the specialist who looks at the mammograms and ultrasound and also MRI. And we also, my team and I also will do any investigations as we need to, so that we can either give people the all clear or to pick up breast cancer as early as we can.
Indeed, I love that. Thank you so much. How long have you been in the industry? Because I know you've got a load of experience.
Ooh, coming up to about 25 years I've been
Yes, look at that. You know a thing or two, don't you? Definitely. So thank you for joining us today. I will come back to you and we'll talk in a little bit more detail just about some of the stuff that you deal with and how people can get more information from your perspective. But Charlene, how are you? Can you hear me?
Yes, I can. How are you, Sasha? I'm good. Thank you.
I'm very good. Thank you for joining us again. Right, so you are a breast screening clinical nurse specialist, also at the Royal Free Hospital, aren't you? I
am, yes.
Now, can you tell us a little bit about what you do, how long you've been doing it, and what your job kind of entails?
Yeah, sure. So I've been working in breast screening for almost a decade, and particularly in breast screening, my role involves just supporting the women as they come through. So helping them to go through, to navigate the process, helping them through assessment if they're called back, and also just offering them support and comfort, but also working closely with consultants, radiologists like Dr. Tay, and the wider team that assists with bookings and so forth.
Nice, I love that. So thank you so much for joining us. I will come back to you because there's so many questions that I've got to throw your way as well. Just before I do, Dr. Anne Murphy, hello.
Hello, how are you?
I'm very good. Thank you for joining us this evening. Right, so you are a GP at the Ellis practice, aren't you?
Yeah.
So can you just talk to me a little bit about what you do and your experience?
So I'm a GP. I work in a medium-sized practice on Shortkill Estate, and we see patients, we do phone calls, we do prescriptions, and sometimes we see people where they've got concerns about their breast or they're having follow-up for a breast cancer.
Yes, indeed. And of course, like I say, I will come to you. I've got so many questions because essentially you are kind of sometimes the first point of call, right? When it comes to breast cancer, yeah. People find a lump, etc. We will get into that, but yes, so it's good to know exactly what you do. So thank you for that. And then of course we have got Hasna. Hasna, how are you?
I'm okay. I'm well. I'm very, very well. Thanks very much.
Amazing. No, thanks for joining us this evening. So you are a service user. Can you tell us just a little bit about your story?
Well, my first diagnosis was in 2006. So I've been using the service for a very, very long time. In 2017, I then got re-diagnosed. So I'm living right now with stage 4 cancer and living on drug trials. Yeah, and I'm alive and happy and, doing it.
Thank you. Well, we are honoured to have you here this evening. Thank you so much for your time. And I will come to you again and ask you some questions just about your experience and and just in general, breast cancer as a topic in general. But first of all, I just kind of want to give, I know it sounds obvious, but there are listeners that maybe don't necessarily know what it is. Can I come to you, Dr. Tay? Could you just tell me, like, what is, in layman's terms, what is breast cancer?
So breast cancer is like any type of cancer in which basically the tissue or the cells in the particular organ, in this particular case, we're talking about breast, grows, basically they don't obey the rules of normal pattern of growth, and therefore they become, if you like, in simplistic terms, out of control. So they grow more than they should do, and therefore take up more resources and that the body normally would require. I want to say something about breast cancer though, because everybody always thinks that breast cancer is the same thing and it's a death sentence. But like everything in life, there's a range of, for instance, you have people who are short and tall, and people who are very tall and people who are very short. Likewise with breast cancer, there are breast cancers which are very slow growing, which probably will never kill you. And at the extreme end, there are some pretty aggressive growing breast cancer. So it's a wide range. But on the whole, people do very well now on modern treatment and with early diagnosis.
Indeed, and I know you're part of that kind of procedure, if you like, with the screening as a radiologist. So roughly, just in general, the types of women that you see, because there is a common misconception that there are only a particular type of woman that would get breast cancer. What type of women, in your experience, have you seen that have been diagnosed?
Well, breast cancer can affect women of, if you like, across a range. The biggest risk for a woman for getting breast cancer is actually getting older, I'm afraid, because like a car that's getting older begins to break down a bit more. Well, the body doesn't work as well as they get older, which is why we start screening from about 50 onwards. So we know that looking at the information we have, that we need to target women who are sort of 50 and over. But having said that, it doesn't mean that women who are younger do not get breast cancer, which is why, information and shows like yourselves is very, very important to give the correct information. So it can be in any women of any age, usually older, very, very uncommon under the age of 20, and certainly not common at all in the very young age group.
Indeed, no, and that's something that I definitely do want to pick up on, because like I say, there are a lot of people, there might be some listeners now tuned into the panel and just feel like, oh, do you know what, I'm young, I'm in my 20s or I'm in my 30s, it doesn't necessarily affect me. But actually, do you know what, it does in some shape or form. If it's not yourself, it could be a relative of yours, it could be your mother or your grandmother or your aunt or someone that's really close to you. And it's kind of about educating. That's what I find with these panel shows in particular. It's really important that we educate people, regardless if you feel like you are at a direct risk now. If you know about it, if you ever do encounter it, you kind of know how to handle it. So that's quite important. And that kind of brings me on to the screening. Before I get to you, Dr. Murphy, and just talk about what someone should do if they find a lump, just generally screening. You said you offer screenings for women over 50. Could you just talk to me a little bit about that, how often and why it's important?
Yes, that's right. So screening, what screening aims to do is to try to pick a disease up early before, so that we can get on with the treatment. And we know that as a rule, the earlier we pick something up, the more likely we'll be able to treat it with less aggressive treatment and be able to offer a cure in the majority of cases. So that's what screening is about. There are actually two different types of screening that we do in the NHS breast screening program, and that's to do with looking at risk. So people who are at what we call population risk, which is people who are at the same type of risk, will be offered breast screening from the age of 50, and they will get a letter of invitation every 3 years, and we will stop inviting them at age 71. So you'll get 3 yearly screening roughly from the age of 50 to 71, after which they will then can call and self-refer, as we call it, for screening every 3 years. So even though we don't invite them anymore, they can still ask to be screened every 3 years. Then there's another
Nice.
group, which is a much smaller group, where we call the very high risk group. So these are women who have got carried the breast cancer gene, and really slightly, and therefore are more at risk of getting breast cancer more often than the general population. We start screening them from as young as 25, and that's a very tailored screening that we offer those women at very high risk.
Yeah, well, that's really interesting. And you talking about high risk, are there any particular factors? I know you said getting old may be one, and you've mentioned genetics, but is there anything else that you would kind of highlight as being a risk factor, if you like, when it comes to breast cancer? Or would you say those are the two major ones?
Well, so we mentioned age. That's probably the thing that most people need to think about. There are what we call the lifestyle risks, for instance. So factors that we can do something about. So things like alcohol consumption, smoking is a general thing, obesity, a high BMI, we know is associated with increased risk as well. Then there are the sort of hormonal factors that we probably can't do a lot about, too much really. So things like having children very late or not having children at all, having periods very early or stopping periods very late. And we also know that if you are, so these are hormonal things really. So likewise, if you're on, that there is a trend with increasing risk if you're on the contraceptive pill, for instance, for a very, very long time, or if you're on HRT for a very, very long time. But we're talking about many, many, many years here.
Right. So how many years would you say we're talking? Because that affects a lot of our young listeners now, you know, because if they are on the contraceptive pill and it's potentially a factor, roughly how many years are we talking?
Yeah, it's very difficult to say because there are many different types of pills and many different types of HRT as well. But the evidence would be, well, certainly longer than 10 years and so on and so forth, the risk starts increasing slightly. And it's all a balance of, if you like, the different factors accumulate together. So we're not talking about only one thing, by and large.
Yeah, and that's really important as well. I mean, some of the factors that you just mentioned in terms of lifestyle risks, things like smoking, alcohol, obesity, BMI, these are things, and I'll keep saying it, these are things that affect us in our younger years. So you know, we've got our listeners now who might think, actually, do you know what, I'm not in my 50s, it doesn't matter, I haven't got to get a screening yet. But if you think about things like this are setting you up for as you get older, you know, so it is very important to make sure that you maintain your lifestyle in a healthy manner so the risks aren't maximized, of course. So I think it's really important. So thank you for giving us context on that. And just very quickly before I move on, in terms of the screening, because you mentioned what it is and how often you do it, how does it work? What do you do in a screening?
So for the normal screening, so we're talking about the age 50 onwards, we do the mammograms. So there's special x-rays of the breast where the breast is actually held together by two sort of plates, if you like. It's slightly uncomfortable because they are pressed together, but that's so that we can get the best possible picture for it. And then that's then read by two different sort of specialist readers to make sure that we get two opinions, to make sure that we try to pick things out if one of the other person hasn't picked it out. So it's a 3 early one. The special one, high risk one that I told you about, starting with the younger women and people who carry the breast cancer gene, for instance. So for those, they're slightly more tailored. So because they're younger women, we start with the MRI first. So there's a special MRI scan where we give them contrast as well. And then when they get to 40, we add in mammograms as well on top of that.
Right. Okay. Really useful. Thank you. Thank you for giving us context on that. So that's kind of, you know, people as they're getting older, whether they're in the high risk category or in the 50+ category, they go and they have their regular screenings, and that's just a check, isn't it, if there are any kind of abnormalities or any kind of cells that they need, you know, you need to keep an eye on, anything like that. That's what the screening does, is that right, you would say?
That's correct. Yeah,
exactly. So so that's when people would come to you kind of as routine. But away from that, you know, if there are people that are home that are maybe have found a lump in their breast, Dr. Murphy, can you just help me with this? Would they come to you as the GP if they found a lump? Well, how does that work?
So yeah, usually people would contact their GP practice, and I would say, although it's helpful to come and see the GP. Actually, if somebody were to see the practice nurse or one of the practice pharmacists, any member of staff in your GP practice will take a lump seriously, and make sure that you get evaluated quickly.
Right.
So should somebody, I don't know, their preferred doctor's on holiday and they get offered an appointment with the practice nurse, by all means take it, because you know, we work as a team, and so all of us will be able to get started, and then if there's a bit of the examination that we can't do, we'll just go and grab one of our colleagues.
Right.
I think the other thing is people think about lumps because that's what everyone talks about. It's not only lumps. If something else peculiar happens to a breast, that's worth also taking seriously. So if the skin on the breast looks funny, not just because you've got a little rash that's there one day and gone the next, but if you've got dimpling, or if it's puckered, or if you've got a persistent rash or redness, that may well be worth taking seriously. And if the nipple has always been one shape and then it starts to look a different shape, it points a different way, or it goes inwards, now that's unusual. That shouldn't really be happening without a reason. If you've got discharge, or you might be breastfeeding, that would be fine. You might be pregnant, and you know, again, that would be fine. But if you've got a discharge without a clear explanation, that would be odd. If you've got a pain, you know, from time to time, I think most women get pain, particularly if you're coming on your period or something. But if you've got a pain that hasn't really got an explanation, that doesn't come and go with your cycle, it's probably not going to turn out to be anything, but it's worth it getting checked just in case.
Right.
And the vast majority of women that come in with a breast symptom, it isn't anything to worry about, but we'd much rather see people generously and kind of see lots of people in order not to miss the woman who actually does have a problem. And our colleagues in the hospital tell us the same. They if we refer people and it turns out there's nothing wrong with them, the nurses and the doctors at the hospital are only too happy.
Yes.
They would rather rather be sure.
Yeah, indeed. So is that what happens then? Someone comes to you, they found a lump, you identify it as being a lump. Do you refer them to the hospital? Is that the process?
So it usually, but not always. So you know, if you've got I don't know, somebody of 23, 24 feeding their first child and they've got a lump, that's probably a milk lump, or it's probably
Indeed,
an
yeah.
infection.
Yeah.
Or you know, if you're 35 and your period's due next week and you've got a little lump, but you don't think it was there last month, you might say, well, let's see if it's still there after your period, and if it is, then we better do something about it.
Right.
But I think, you know, a lump that doesn't have an obvious, reliable explanation, the best way to evaluate that is in a one-stop breast clinic. So we'd normally refer up, and then the necessary scans and the tests will be done there and then.
Right. Okay. And we talk about finding a lump and coming to you. Do you know, like, how do people check for lumps? How does that work, that process?
So what's normally recommended is that people are breast aware. So if you're in the shower and you're having a wash, don't use the flannel on your boobs. Use your hand so that you know what they feel like. I'm not saying you can't give yourself a good scrub with the flannel if that's what works for you in terms of your hygiene routines, but make sure that you know what your breast feels like, so you know what's normal for you, and if there's something that changes, you'll be aware. It won't be it won't be out of the blue.
Right. Yeah, that's really good advice, actually, because I know loads of people that wouldn't even think when they're in the shower to just have a quick feel and just make sure everything feels normal, because you kind of just expect it to be as it should be, you know, unless you feel a pain. People don't normally do that, so that's really good advice, actually. So they come in the clinic. Sorry, off you go.
No, that's right. And because everyone's breasts are different, equally, you don't want people to be panicking over a perfectly normal breast that they've been walking around with all their life.
Yes, indeed.
And everyone forgets that your breast actually extends right up into your armpit, but very few people forget to wash their armpit. So that's quite a good way of making sure that you have checked your whole breast.
And would you recommend washing your armpit with your hands as well, just to feel around?
I personally, I would give it a scrub with the flannel first,
Okay.
but maybe the second wash with your hand.
Yeah, just have a little feel, make sure everything feels as it should. So when you refer people that you kind of suspect it may be something a little bit more sinister, do you refer them to the hospital, and then that's kind of when they're in the hands of, say, Dr. Tay and Charlene? Do you kind of advise people to, you know, do self-referrals instead of coming to the GP, or is it always actually just come and see us even if you're unsure?
So what we try and do is we've got something called the 2-week wait pathway, which is that if the patient and the doctor or the pharmacist or the practice member are concerned about a breast abnormality, the hospital will guarantee to see them within 2 weeks.
Okay.
And I think that's probably one of the reasons why they haven't got a self-referral pathway, because they're really hot on making sure that people shouldn't wait any longer than 14 days from when they raise the concern to when they get seen in a specialist clinic. But, you know, we don't necessarily examine everybody. We'll examine most people. But if somebody rings me on a Friday night because they're concerned about a breast lump, and it's a genuine breast lump, it's not I'm not sure if it's there or it's not there, and it's been there for a while, and they've been trying to get the courage to speak about it, I'm probably going to put the referral through, because I don't want them to be worried all weekend thinking, I'm sitting here now with my lump, and when I go in on Monday, she might not take me serious. You know, I know I would, but they don't know that.
Indeed.
100%, and so, you know, by feeling alone, a GP isn't going to say, your breast lump is definitely nothing, unless it's a spot or there's a visible alternative explanation. But somebody who's got a deep abnormality in their breast, and that's been persistent, we aren't going to fob you off. We are going to get our colleagues in the hospital to do some fairly careful checks, so that when you leave them, you can be quite sure whether or not you have anything to worry about. Because much of the job at the clinic is of reassuring people who haven't got breast cancer. 9 out of 10 people, even more than that, that we send in, come away going, oh, that was a load of worry for nothing, good, and then they get on with their lives. And I think I don't want to make it too big a thing about people going up to the one-stop shop. They're very nice, it's very efficient, and it means that people who need treatment get it very quickly, and people who don't need treatment get back to their normal day and, you know, just keep giving their boobs a wash when they're in the shower.
Indeed. And just very quickly before I move on to Charlene, when they come to you, you say you examine them. What do you do? Because we know that when they get to Dr. Tay, it's MRI scans and mammograms. When they come to you, how does that work?
No, nothing as fancy as that. We talk to them, and then, you know, just put our hands on the place where they show us the problem and check the breast and the armpits.
Yeah, and you just have a feel. Obviously, you've got a whole load of experience, so you kind of know what feels like it needs a little bit more investigating.
Well, I think, you know, if the patient has found something that they feel needs explanation, there are very few people who will imagine something. There's occasionally somebody where something's there, but you've got a good alternative explanation, like, no, that's the end of your rib or something.
Oh, okay.
But you know, most people who think they need referring do need referring. It's patients are quite sensible.
Yeah, agreed, actually. And then when you get, you know, there was somebody that came to you that had some breast pain but not a lump, should they be worried, you think? Could that be something?
So I think breast pain is less likely to be something serious. It's only occasionally a sign of breast cancer. And so I think when we say to people to talk to us about breast pain, we're being precautionary, because very occasionally it turns out to be something nasty. Most of the time, we're able to examine them, talk to them, reassure them, and not need to take any further action. But again, we'd rather do that for a number of people than miss the person where there is a significant problem.
Yeah. Agreed. Thank you so much, Dr. Anne Murphy. Really appreciate that insight there. Charlene, how are you? Can you hear me?
Yeah, can hear you, Sasha.
Excellent. So, you know, people have, say, for example, there is a person, they've gone to Dr. Murphy, she's had a feel, said, actually, do you know what, this needs a little bit more investigating. They've come into the hospital, Dr. Tay's had a look at them and done some scans. What kind of support do you offer those patients?
Well, it depends on where in the pathway they come into. So if they've come in for further assessment, because initially they have their screening mammogram, this could be at a static site or on a mobile unit. They only come to us after they've a problem has been picked up and they need further assessment. So at that point, when they attend that appointment, after they've been checked in, then they will have a chat. I'll have a chat with them and explain why they've been asked to come back, and also explain what the process will be. Some of them might need another mammogram, there might be an ultrasound scan, there might be a biopsy involved. So it's just talking them through that process and making sure that they understand what is going to be happening and they're fully aware of how the process works.
And do you find that a lot of people that you come across don't know, haven't done any research and are need a little bit more education about the topic?
It's a bit of a mixed bag. There are some ladies who, you know, especially when they've received a letter when they've been asked to come back, which we call when they've been recalled, they will go onto Google, they will look up information. They may have relatives who have been through the similar process. So sometimes you find people have got mixed views on what the process actually entails. So it's really important that at that point we allay their fears and make sure that they understand why they've been recalled and that it's different. As Dr. Tay and Dr. Murphy have mentioned earlier, everyone is different, and a symptom that may be in a problem for somebody else might not necessarily signify the same for them. So there's a lot of anxiety and there's a lot of really support in allaying those fears.
Indeed, and it sounds like you work very closely with them. What's that like for you? You know, just working closely with these women in one of their most vulnerable times. What's that like?
Personally, I would say it's a unique privilege to be at that point to support them, because it's both a scary time and a very anxiety-inducing time for these ladies, and to have somebody that they can just talk to, somebody who can understand to a certain extent what they're going through, and just being able to spend that time and give them the information they need according to what their needs are at that moment is absolutely a unique privilege. And I enjoy it's one part of my job that I really love, connecting with the women and finding out what matters to them and what's important for them.
Indeed. I mean, you obviously do an amazing job. We are so grateful to have people like you in the service helping and educating, because I think that's really, really key to getting people through what is quite a traumatic time. You know, so if there was somebody that has been, say, sent a letter to come back for further tests and further screenings, do you think initially they should be worried in your experience, or do you think it could be just procedure protocol, if you like?
I think it's quite normal to be worried
Charlene,
after you've gone for a
hear me?
mammogram. Yeah, I can hear you. Can you hear me?
She's frozen.
Oh.
Charlene, can you hear me?
Yeah, I can hear you.
There
Can
we
you
go.
hear me now?
Yeah, sorry,
Yeah.
we lost you there for a second. It must have been our internet. Did you hear me? Would you like me to carry on? I was just basically saying that you know, if someone has been told that they need to come back for further tests, and they've come and they you know, they're speaking to you, do you think initially they should be worried, or is it just sometimes it's just procedure, it's just protocol, it's just trying to make sure that we have eliminated anything that we thought it might be?
I think it's natural to be worried when you're being asked to come back, you know, so I think most ladies that actually come back are worried to some extent. But again, it depends on the reason why they've been asked to come back. So it's just explaining that process and reassuring them that it doesn't necessarily mean that because they've been called back, they have a cancer. It doesn't mean that. It just means we want to look closely at maybe an area that we're not quite sure of, or something that's come up, or maybe they've actually presented with a lump on their screening mammogram and we just need to investigate that further.
Indeed. And you say that it kind of depends on what they need, for example. Could you give some examples of some of the instances that you've come across just in your career when it comes to breast cancer? What kind of things have you come across?
I think the anxiety that just comes with breast cancer. Some people have got children, some people have got home situations that are different, employment, economic, there's always a whole host. It's not just you've come for a mammogram, you've come for further tests, and that's it. There's a whole human being behind that who's got a whole lifestyle behind them. So sometimes actually it's not directed to the process itself, but it's their own social or personal issues. And it's just helping them to work around that and really prioritize their health.
Indeed. And do you just support the patient, or do you support their families and people around them as well?
Because I'm in screening at the moment, it's just the patient.
Just the
if
patient,
they do get a diagnosis of cancer, then they move across to the symptomatic service. And again, there will be counterparts like myself or clinical nurse specialists who will support them and their family if need be. And again, there'll be further resources at that point according to what they need specifically.
Amazing.
If I could kind of provide some further context as well to what Charlene was saying about the recall. Absolutely right. The majority of patients, women, have been called back. It's just to work out what we've seen on a mammogram. To give you an idea, if I want to put a number on it, so let's say out of 1,000 women we screened, about 50 will call back for the test to have a look and see. So that's quite a small number. And out of the 50, the majority will be fine. So, and we know in the screening program, out of the 1,000 that we screened, we'll pick up about 8 cancers out of 1,000. So you can see that out of the 50 will call back, the number then is not really as, as much, as high. Yeah. So a lot of times we're just working things out, making sure it's nothing to worry about. A bit like what Anne said to you, really. So refer to the breast clinic so that we could exclude the things that we don't have to worry about, and importantly, pick up the things that we need to get treatment on.
Indeed. No, I mean, the process just literally sounds like everybody is just there. All of you are there to just help people get through it and get the diagnosis and literally get the treatment as quickly as you can, which is what we need when it comes to this, because there is that common misconception, like you were saying earlier, Dr. Tay, that, when people think that they're diagnosed with breast cancer, they think that's it. And it doesn't necessarily have to be it. Of course, people like yourself and Charlene, and of course, Dr. Murphy, you work really hard to make sure that people are informed and do kind of get the best possible opportunity to overcome it. So thank you all for that, which leads me nicely on to you, Hasna. How are you? Can you hear me?
Yeah, I can. Can you hear me?
I can. Can you talk me through a little bit about your experience? So the first time you were diagnosed, would you mind talking us through that?
All right, so this is 19 years ago, right? So what cancer was then, it's not now, so within that 2 decades of time, I fell into the category of what the other doctors were talking about. I have the BRCA gene, I have the cancer gene. I was a young mother breastfeeding and had the lumps, went in, was told, it's breastfeeding breasts, which I mean, I know because I had another child before that. So, but at that point, 19 years ago, it wasn't taken seriously. I was then sent away. I kept on breastfeeding my child, and the lump kept on growing. And I took it into my own hands, went into Central Middlesex Hospital, and, more or less, sort of said, this is exactly what I'm feeling. This is what I'm doing. And after that, then I got the 2-week referral letter to go forward, which when I was then diagnosed, I was diagnosed at stage 3 breast cancer, because I do have the gene, and it's a different type of cancer, just like what Dr. Tai was saying. It's a very aggressive type of cancer. And it doesn't only go to the breast, but it also goes to the ovaries after time. So, but that was the first diagnosis. And I believe now things are much, much better. People are really signposted in different areas. However, being signposted and being a user, so my first experience is different now to my second experience. Now I'm more informed. Now I have more information on my specific type of cancer and how and where and what is available. However, you know, like in Brent, there's a lot of people who don't, a lot of women, I must say, who don't come across to challenge anything that, you know, anybody in power says to them, because either they, you know, don't have all the confidence or, you know, to question or even ask. And sometimes I think as users, we need to be asking more questions, because the doctors and the consultants and everyone, the entire team really want everyone to want questions to be asked so that they can help us, you know. And I think that's one of the things. If we don't ask more questions, we sort of get left behind. And
Right.
I think where we need to do the link, we need to make that link now.
Right, okay. And by we, do you mean just service users or everybody?
Anyone who's using service users, anyone who's using, I mean, today we're speaking about breast cancer. So
Yeah.
specific for people who are on that journey or believing to go on that journey, you know, to mean, ask the questions. Because I mean, what one GP said to me, it's better to be an informed patient. And when he said that to me, it was a light bulb like clicked into my head.
Yeah.
You know, I started understanding what this test mean, what that meant, what this meant, and was able to put a whole picture together in order for the team in the NHS and myself to work together to come up with a better plan. You know, because like, different types of cancers, you know what I mean? Some cancers, early detection and, you know, radiation or something, it's easy, but then, you know, again, it's aggressive, but then you don't know, sometime with the screening, you know what I mean?
Yeah.
I believe younger women should be screened, you know what I mean? Because I was young and I, you know what I mean? And I knew that I wasn't taking no for an answer at that point. So,
do you mind me asking how young you were at the time?
I was 28.
Oh, wow. Okay.
Yeah.
28 years old. Yeah.
8. And that this was I had my second child. And
Right.
that's when, but then when I became 30, 32, I found out that I had the BRCA gene. So then I was able to make better and stronger decisions now, knowing what I have, where, you know, the better treatment is or different things like that. So in 2017, I had another child, and that's when I got re-diagnosed with stage 4 cancer, metastasized. And but at that point, they gave me a life expectancy, but I was able to, I had all the information. I was ready, you know, I was ready for the doctor that I spoke to. And I sort of explained to him what, you know, I need a referral to this, I need a referral to that, because this is where the best treatment would be for somebody in my situation, you know. But again, you know, it's not this confidence, I didn't have this in the beginning, you know. So it's just about, for me and other women like me, because I do know other users who have breast cancer in Brent, you know, and they struggle sometimes because they don't have like all the ability. Some of them they speak 2 languages or 3 languages, you know what I mean? And they get mumbled up with different words and things like that. So, and then it's like, it's a whole other, so sometimes when the consultant gives letters, you have to read down that letter with a fine-tooth comb, just really going through it to sort of understand what's really taking place, you know? But the consultants do answer if, you know, you do ask the questions, you know?
Of course. So, so just going back to the first time when you were just 28 years old. So, what treatment did you have the first time?
So I had chemotherapy, radiation, and a lumpectomy.
Okay. And could you explain what those are, just for our listeners who don't know what they are?
Chemotherapy, well, chemotherapy is a transfusion, an intravenous transfusion, meaning going into your veins, that more or less kills the cells that is doing harm to the body, but also kills other cells in the body. Radiation, I had radiation directly to where the lump was, which took about 6 weeks, I think. And a lumpectomy is where they cut out piece of it to the piece that's around it that's damaged, I guess, you know what I mean? And try to get most of the tissues on the inside, cut away most of it so that it doesn't spread to the other side.
Right. So you had that done, and when you kind of had that done, did they say to you that you had the all clear? How long did you have the all clear for?
Yeah, so basically I had the all clear for about 7 years.
Okay.
And after that 7 years, so one of the things at that point I know now then that I had to be checked, and I was not letting up on my checks not being dealt with, you know what I mean? I was one of those type of patients who made sure I am getting checked today, because, this is a serious situation. It's not a normal cancer. So I knew at that point how to get it checked,
Yeah. And then, so then was you ever told that there's a possibility it may come back? Is that how it works once you've?
Well, with the BRCA gene, it will come back. It's just a matter of time.
Okay. So you were prepared?
Not in the beginning, not in the beginning, but like after, because I had a surgery also that reconstructed my breasts, which used my tissues from my belly. And after that, then I had that information. I knew the information, and I knew what I could have got because I have the BRCA gene.
Right. Okay. So right now, where are you at now? I know you said you've got stage 4, but is there any treatment that you're undergoing? What's the process now? What's happening now?
For the last 6 years, I've been at the Royal Marsden on different clinical trials. So I go through clinical trials, and this is one of the things that I want to talk about. People need to come out and try to use more clinical trials because it's available for us to use. And I mean, I was on one clinical trial that lasted 8 months. I mean, they gave me 18 months to live in 2017. And the other trial that I went on was 14 months. The one that I'm on right now, it's been 2.5 years. And I mean, with that opportunity, I saw my son got married. I saw my granddaughter being born. I mean, and this was 2017 when, to me, they told you had 18 months to live. And I was like, so putting ourselves forward for trials like this allows us to think of the future of this, disease, what I mean? Because it has to have a future, because sometimes now, as a 20-year user, of the system within the NHS and cancer, cancer has to move from awareness to action. And by doing things and interviews like these and making people hear more of it and personalizing it, it's what is needed, because this is the actions that we need to do now so that the future is different.
Yeah, of course. And what do you think about kind of educating younger people, maybe in schools? Is that something that you think should be pushed forward as well?
Definitely, because it can only help. I mean, like there's programs, PHSE programs, small programs, where children can learn to speak about different type of diseases, heart diseases, what I mean, different types of things, because this has a knock-on effect. I have children who went through the school system, and, it has a knock-on effect with them. So if they learn from early, the whole school, what I mean, the whole education system, understands from an earlier stage how to go about things, or where to help, or how to help. And even sometimes, even in their own little worlds, you know what I mean? Like how to help a friend, you know, because my children went through school and they had their personal friends who knew about the situation and helped them, you know, because of the schools, because of some of the schools, I had to go in to talk to the principals to let them know how to deal with these children, you know, with my children, because it's not the same situation, you know what I mean? They have different situations, social, you know, different things that they went through at that point, you know, seeing a mom challenged by, you know, breast cancer.
Yes, indeed. No, I get that. And it's definitely important that we do support the children and the relatives and the friends of people that are, you know, have got breast cancer, because, you know, you're only as strong as your support network. You know, if you've got people around you that understand and are informed and really are there to just be that person that can help you through, as well as the Charlenes who are there to kind of just talk you through it and help explain anything that you don't know. Those are the things that help kind of boost your, I know it sounds, some people might think it's a bit far-fetched, but your whole mentality. One of my really good friends had cancer. He had stage 4 cancer. It wasn't breast cancer, of course, but because of, I believe, because of his mindset and his mentality, and he was always positive, as well as, of course, the treatment, that's what helped him get through. You know, he fought and he didn't give up, and now he's clear, he's cancer free. So I think supporting people, regardless of what cancer it is always really, really important. So you know, definitely the children of mothers, you mentioned your children as well, making sure that they've got the support, making sure that everyone else is educated and informed. I mean, you said the first time you had cancer you weren't as informed as you are now. Did you find that the resources are more available now, or do you think that there needs to be more done to push those resources forward?
There definitely needs more to push the resources forward, because, you know, it's sort of like you have to sort of ask, you know, and keep on asking. Whereas I believe, I mean, the hospital that I'm at is a specialist hospital, so it's known for only looking after the cancer users, you know. So some of the questions there, I don't have to ask it. But if I go into another hospital that is not a specialist hospital, you know, I'm having to ask all sorts of questions. How, where, why, how do you do this? You know, different things like that. And because I ask questions, I more or less, you know, get through with what I want to do. But because there are other people who don't, and they just listen, there's a problem there. So we need to either, so there's a lot of volunteering, you know, at the other hospital there, you know, just basically giving people information over and over and over and over. And these are the things that are needed, you know, like, I mean, even like in Brent here, we need a wellness center here in Brent, you know, because in this center, we would have to do things that can help the people, especially with cancer, to really get what is personalized to them or personalized to their type of cancers. You know, it's something more, what word I was looking for, something more, you know, where the whole thing works together.
Yeah,
you know?
Yeah. No, definitely. Thank you for that, Hasna. Really, really insightful, actually. Thank you. And we are talking about, you know, being inclusive and making sure everybody is involved and making sure everyone is aware and understands, you know, what breast cancer is, the different types of breast cancer, the treatments, how to get yourself checked, how to, what to expect when you do go for a screening. But I mean, I do want to be inclusive, so I just want to kind of touch upon this. Charlene or Dr. Tay, I'm not sure which one of you would answer this best, but what happens in the case of transgender individuals? How does that work?
Okay, so that's very topical at the moment, clearly. Now, probably one of the things that you need to understand about how we know who to invite for screening is that we invite women from a GP registered. So somebody who's registered at, for instance, and surgery, we will know they're registered as female. We will invite them for screening. So it's how they get onto our books, if you like, because otherwise we wouldn't know who to invite. for the on the transgender side, if the individual is registered as female, they will get invited anyway. So they will get their screening as per usual. Now, that means that we've got a little bit of a blind spot. So the blind spot are the transgender people who have been on hormones, developed breast tissue, but still register as male on the books of the GP. We wouldn't know that they're there. However, we have been telling people that they still have a right to be screened. We don't know who they are, but they can go to the surgery and say, look, I'm female, I have got breast tissue. Even though I may be registered as male, can I please have my mammograms? And they can be referred to their local hospital, not through screening because we don't have them on our books, but they can still invite themselves through their GP for breast screening.
Amazing. Thank you for giving us that. And literally, I just think this has been so insightful. So thank you all for kind of giving us your insight into the topic, if you like. But Charlene, I just want to quickly talk to you. I know we haven't got very long left. Is there something from your perspective that you think is really important for our listeners to kind of take away with them and make sure that they really understand?
I think it's very important for women who are aged 50, at the moment, especially between 50 and 53, if they've not responded to their invitation for breast screening, please contact the Breast Hub, the London Breast Hub, and tell them, and then we can book you in, because screening is important. It saves lives, you know, so it's important that women go out there and have their screening mammograms. It can be uncomfortable, but it's very important.
It's definitely worth it, right? And do you find that on the booking side of things, you are reaching out to a load of people and not many people are coming back, or are people usually quite responsive?
We do have some who are responsive, but also we do have other women who are not either responding, or some maybe have opted out previously, but it's important if they can, especially if they've received an invite, to contact us at this moment.
Really useful. And can you just give me a very quick rundown of what the opting out is, because maybe some of our listeners are not sure what that means?
So as Dr. Tay's already mentioned, women are routinely invited between their 50th and 53rd birthday. They do have an option to say they don't want to have the mammogram, you know, and they can let us know. So once they've let us know that, then they won't be invited, but they can also contact us when they want to opt back in. So it doesn't mean that they don't. And anyone who's over 71 who still wants to have a mammogram again can contact us, you know, because they won't be routinely invited for screening.
Amazing, thank you. So it's really important, if you are listening, whether it's your parents, your grandparents, your aunts, just let them know, you know, if they have received a letter about breast screening, please do respond. It could save their life. Thank you so much for that, Charlene. Dr. Tay, what would you say is one very important thing that you'd like our listeners to take away with them today?
Like Hassan said, I think information is very, very important. We have, if your listeners Google London breast screening, we have on that page information about breast screening, what's it about. We have links to how to self-examine, how to look out for signs through the sort of Macmillan site about what things to look out for, which was mentioned earlier. We also have a video from Royal Marsden Partners, who we work very closely with, about breast pain, which seems to be something which is increasing quite a lot. I mean, 10 years ago, 20 years ago, I hardly see any women with or girls with breast pain. Now it's about half my patients I see have got breast pain. And lastly, to support what Hassan said about entering trials if offered, or looking out for them. Trials is not just about treatment and about how it can advance treatment options. We also have trials at the moment at breast screening, looking at what tests will suit different people best. For instance, people with dense breast, for instance. So, and we find that actually, sadly, the women from Brent are very, very reluctant to come forward and join our trials to try to get the best detection for women. So encourage people to go forward for trials, encourage people to look for the right information.
Amazing. And we will put those resources up as well, so you know, so our listeners can make sure they find them and they are aware of them. Dr. Murphy. what would you say, apart from which I've taken away, make sure you wash under your arms and wash your breasts with your hands and not necessarily just a flannel. I love that. Is there anything else that you think is important that our listeners can take away with them today?
So I'd echo what Hasna says about that it is difficult for many people in Brent to speak up and get heard, and that if people feel they're not being heard, if women are not being heard, don't give up. Just keep bugging the staff in front of you until you are properly heard. And I think also as a community that we need to be supporting each other to make sure that people with disabilities can get screened, that if our neighbour, her English isn't so good, that we might give her a hand to rearrange her inconvenient appointment to a better day rather than feeling she just has to take what she's given. That together we can support each other, and if we do that, the NHS will continue to get more responsive. It's already more responsive than it was 20 years ago, but we've still got a long way to go. And it shouldn't be the case that women in Brent are being screened less often, treated more slowly, in clinical trials less than average. That's not right. That's discrimination. And I think we need to, as a community of patients and professionals, to be demanding better. And if we do that together, I would hope that's what we'll see.
Indeed. Excellent. Thank you so much. And Hasna, just before we head out, what would be the one thing very quickly that you would like our listeners to take away with them?
Well, there's so many things, but early detection saved my life, although it was at a stage 4 cancer. But being able to detect things, and trust your body knows, you know this body, just as Dr. Murphy said, I mean, I'm always, creaming up myself, making sure, you know what I mean, feeling everywhere to make sure that no lumps and bumps, you know what I mean? That's another thing, but as a community, we have more work to do because of where we live, and the work just has to be done, and we all reach out to get the work done. The community that stays together, we would thrive, we would really, so, I mean, because 20 years ago, it wasn't like this. So we can only strive for the future, and try
and get better. But yes, thank you so much. Thank you so much, Hasna, Dr. Tay, Charlene, and Dr. Murphy, for your time today. It's been so informative. Really, really enjoyed talking and finding out a little bit more. As you at home are listening, please remember to Google London breast screening, and you can find out loads more information. There are loads of links and resources on there. Remember, breast cancer is not a death sentence. Make sure you get referred, make sure you see the experts who will find out and give you a little bit more information. But that one there is the end of our panel show today. Miss Bex is up next.